Okay, so the next video is cervical neurogenic. So when we're thinking neurogenic, we're thinking myotomes, dermatomes, reflexes, including our red flag reflexes, and then we've also got neurodynamics to finish as well. So we'll start off with cervical spine. So for the cervical spine, myotomes, you would do them sat on the edge of the bed, and we'd work through systematically each different myotome. Okay, so starting off at the top, we're going to do C1, C2, then C3, all the way down until we get to T1. Okay, so you go through your stages, so you're going to explain the procedure to the patient first, then you give them a demonstration of what's going to be involved, and then you apply gentle isometric resistance, building up to maximal resistance as you work through each one. You're comparing one side to the other to see if there's any areas of weakness. Okay, so I'm just going to hand over to me doing it with Tom. So first of all, Tom, I'm going to get you to push your head against me into different positions. Okay, so first one, just push the back of your head against my hand there. Relax. Push the forehead into my hand. Relax. And side of your head into my hand. And side of the head into my hand. Good. We next move on then to shoulder elevation. Okay, so just get to try and elevate your shoulders up towards the ceiling. Relax. And then abduction, so arms out to your side. And don't let me push down. And relax. Same on the other side. Don't let me push down. Good. Palms facing the ceiling out in front of you like that. And try and push the back of your hands down in towards me. Excellent. And one at a time up towards the ceiling. And up towards the ceiling. Good. And you do a thumbs up position. Don't let me pull your thumb down. Don't let me pull your thumb down. Put my fingers in your fist there, just try and squeeze my fingers. Good. Same on the other side. And then finally for T1 with your fingers apart there. My hands inside, just try and squash my fingers together. And same on the other side. Okay, so all the time comparing one side to the other, looking for a weakness or a perception of weakness. So remember, it might not be that you can detect the weakness, but the patient can't feel that they can push as hard on one side compared to the other. So after we've done our myotome checks, we then move on to our dermatomes. So for dermatomes, we've got light touch, vibration, and sharp blunt. For this test, we just want to see you do the light touch version. However, you should have a knowledge about how to test vibration and pinprick, just in case there's time for you to show that at the end, or you could just verbalise that there are other sensation tests that you can perform as well. With the dermatomes, we work distally to proximally in terms of the nerve route. So our first one's going to be T2 on the inside of the upper arm, T1, C8, C7, C6, C5, and then finally C4 coming back across the clavicle. In assessment conditions, you get the patient to dress down, so top off, so it's skin on skin. We won't do that just for now. And again, you're comparing one side to the other. What we're looking for is, again, that you've explained the procedure to the patient first, with their eyes open. You demonstrate the procedure to the patient. Then really important that you get them to close their eyes when you're actually doing the test. And you're comparing one side to the other. What we use for light touch is cotton wool, and you're dabbing the skin with the cotton wool, not stroking the skin. Okay, so we'll work through distally to proximally with each of them. Okay, Tom, so I'm going to use cotton wool to dab either sides. Just want you to let me know if it feels the same both sides or if there's a difference between the two. As I'm going through, you're going to have your eyes closed just so you can kind of appreciate the different sensations. So just to show you what it's going to involve, it's going to be me tapping on the skin like that. But I just want you to know if you feel the same both sides there. Okay, so we'll start off with T2, so upper inner arm. Okay, and we're going to work our way down to sets of orange shirts. Same on this side, still the same both sides there. And then just keep turning your palms up towards the ceiling. And go down the inner forearm there for T1. And feel the same as that. Little finger size. The C8, and feel the same. C7 is the long middle finger. Feel the same there. Good. C6 then coming into the thumb side. And feel the same as that. C5 working up the outside of the arm. Same both sides there. And then finally C4 across the clavicles at the front there. Again, feel the same there. Okay, so let's say there was a sensation difference. What we do is get the patient to quantify that difference by saying, if this is 100% normal on this side, what would you score this at on the other side? So it could well be that there's a 25% loss, therefore we'd say that there's 75% sensation on the symptomatic side. If we were going to do that for vibration, we'd still work in the same dermatomes using a tuning fork, hit it against something firm like the table until it vibrates, then we hold the nib of the tuning fork against a bony landmark within each of those dermatomal areas. So it could be the lateral epicondyle, it could be the distal phalanx, depending on what dermatome we're working in, or the clavicle is a good one for C4. Pinprick and sharp blunts, we've got the neurotip, so one sharp end and one blunt end. What we do first is we get the patient to understand what sharp feels like and what blunt feels like by turning it over. Same again, they close their eyes and then they have to let you know whether you're using the sharp end or the blunt end as we work through those different dermatomes in the same order that we just did with light touch. The third stage of neurogenic assessment for cervical is reflexes. So using the reflex hammer, first little prompt there is just notice how I had it resting on the bed. So health and safety, making sure it's not stood on its end, it's a spike to stab your eye on. So we're going to work through 3 reflexes here, deep tendon reflexes for the biceps, brachioradialis and the triceps as well. So with these ones we're comparing left to right with each of them. Remember, hyporeflexiveness is not a red flag sign as long as it's comparable one side to the other. So just with the backs of your hands just resting on your lap. So find the biceps tendon and place my thumb on it. Just let it relax, tap. There we go. And we compare to the other side. So thumb on the biceps tendon. You can see there the reflexes I knock onto Tom's arm. Brachioradialis is in like a hand-shaped position and then turning upwards. Brachioradialis down into the mid part of the forearm. Again, we can see that reflex there as I tap. And same on this side. And finally, the triceps tendon. Come behind the patient, take their arm out into abduction of the shoulder to 90 degrees, and then flexion the elbow and just let your arm just go nice and loose. I can put my thumb on the olecranon, or just above the olecranon on the triceps tendon. Let your arms go floppy there. And again, I'm looking for the reflex. The triceps, same on the other side. The reflex of the triceps there. The last reflex test is the red flag sign, so Hoffman's test, which is for upper motor neuron disease, so problems with the brain and the spinal cords. So for this one, I'm going to flick the distal phalanx of the middle finger, whilst keeping the ring finger, or the index finger, sorry, and the thumb free. A negative test would be that nothing happens. A positive test, as in we don't want to see it, is that the index finger and the thumb come together. Okay, so just going to sit alongside Tom, holding onto your hand there. Keep these 2 fingers free and relaxed. Just let your hand go floppy. Okay, so just flick the distal phalanx. Hopefully nothing will happen, which it hasn't. A positive test would be that the index finger and the thumb, come together like that. Ring finger. Same on the other side. So I'll take the support of Tom's hand, make sure the index finger and the thumb are relaxed. Flick the distal phalanx. I'm just observing what happens to the index finger and the thumb. The final stage then for neurogenic is upper limb tension test, which is our neurodynamic test for the upper limb. So for this one, you have to have a line on your back and tongue with your head just at this side. Okay, so for neurodynamic tests here, I'll do it both sides so you can see, and you would do it both sides on the assessment as well as a way of comparing one side to the other. What you do is you take the arm out into 90 degrees abduction, you can rest it on your thigh. Use your other hand to fix the shoulder. This isn't providing a cord ad force, it's literally just there to fix. Palm on palm, you're going to run through different stages of wrist and finger extension, elbow extension, forearm supination, and shoulder external rotation. Feel that stretch in there? And then finally the sensitizer is if you take your right ear to your right shoulder, so side bend in down. Okay, so you side bend there to see whether that increases the symptoms or not. And relax down. So you can be asymptomatic with these tests, as in having no problems and still being tight, so it's worth then comparing to the other side as always. Just so you can see from the other side as well, going to abduction of the shoulder 90 degrees, hand on the shoulder, wrist and fingers into extension, elbow extension, forearm supination and shoulder external rotation, and then side flex of the neck. Good. Relax with that. Good, so we've also briefly gone through nerve palpation, which I've removed from the assessment. However, if you have learned nerve palpation, then this would be the time then to go through the palpation there as well. But as I say, it's extra in there rather than it being a requirement of the test. And that's cervical neurogenic.